welcome to New Orleans. We're here at AsMA 2023. Excited just to kind of talk about what we're most excited about for this meeting, and we have new friends we've met along the way. So I'm Kyle. I'm a medical student, and we are interested in space medicine and all the things that this meeting is about. So yeah, just really excited to have other friends here. You guys want to introduce yourself?
Sure. So my name's Ryan. It's really nice to be doing another one of these podcasts after about a year hiatus since the last time we put something out. But I guess updates on my side of things. Since the last time we did a podcast, I have since finished my medical school at Michigan State in Grand Rapids, and now I am going to be in the Detroit area for my residency in internal medicine. So from my perspective, I'll just say at this point, before we get into things, just leafing through the contents of what we're going to be talking about over the next week. There's a lot of things to be excited about. So on that theme, I know we're throwing around the word excitement quite a lot here, and hopefully that captures the spirit of kind of the mood before the conference actually begins. But yeah, it's good to be back.
Welcome, Dr. Pinty. Congrats on graduating.
Of course, thanks.
And my name's Daniel. I'm a fourth year at Wake Forest. I'm thinking about applying anesthesiology. I started an aerospace medicine interest group my first year of med school at Wake. I've sort of always had the interest peripherally, like in undergrad, but when I found out about space medicine and some of the opportunities that flight surgeons have as careers, I kind of devoted way more time towards it when I started medical school. And this is my first AsMA meeting, so I'm really excited to be here and meet everyone and attend the talks. And I'm glad I was able to do it before I finished medical school, because I wanted to go last year, but I was in my third year and it was hard to get time off to attend this meeting, so I'm glad that I have the time to attend this meeting this year.
Yeah, it's been really nice to get to know you over the probably about the last year. We've been chatting over a Discord server, getting to know you, but yeah, getting to see and meet you in person has been really awesome. And yeah, excited to have you here. Do you mind telling me, like, when was that first moment that you discovered that space medicine existed at all?
Oh, that's a good question. First moment. I initially wrote my medical school essay about sports medicine, because I did like a lot of calisthenics stuff, and I had an injury, and my first interactions with physicians for a long time was with a sports medicine doctor. And I remember he had a friend, he was telling me in clinic about one of his friends who was doing aerospace medicine, and I was a senior at that time in undergrad, and so I looked it up afterwards, and I think that just kind of sent me spiraling down this path. So it wasn't one maybe moment or some sort of epiphany that wow, this is the career for me, but it was just kind of a long-term thing of doing my own research about it, getting connected with individuals, and it's kind of built up my appreciation for this field and passion for it.
Yeah, it feels like when you hear about it, there's only a subset of a couple reactions you can have to it, and one of those is okay, what do you mean? What is how do you do it? Who does it? Where does it happen? And that curiosity about it just fuels a huge amount of interest that kind of feeds on itself, and then you end up at AsMA.
Yeah. I think it definitely helps to have appreciation of space and exploration beforehand. I think a lot of people might hear about it in medicine, but they've never loved or been involved in space in any way. So for them, it's like, okay, this is a cool field. But if you're someone who like, I mean, I grew up like watching like space anime, reading like science fiction. So I already had like this deep base like to build off of. So it didn't take that much to like pique my interest.
Yeah, I feel like there was like a tension in like, you know, really liking space and then medicine being over here and like really liking medicine and then just building up those interests and not realizing that there was a bridge. And then when you finally find that there's a bridge between those things, you're like, oh.
Yeah, I think that's the best way to describe like how I felt.
Yeah.
When I found out like that there was that bridge.
Yeah. So what were some of those like space anime contents? Like what were your favorite?
Yeah, we got Outlaw Star. I was like 5 years old when I watched that. That's super old.
Okay, yeah, I actually haven't seen that.
Yeah, Cowboy Bebop's a super popular one.
That's a classic. Yeah.
That's a classic. There's like, I mean, there's some like childish ones like Gurren Lagann is one.
I've never seen that. That's a good one.
Yeah. That's all I can think of right now. I mean, I'm sure there are others, but like those are like the classics.
Yeah. Those are good.
And Star Wars, of course.
Yeah.
That's like a OG.
Yeah. The space medicine a little lacking in Star Wars, but you know, whatever.
Yeah.
I'm specifically talking about one of the more recent Star Wars movies where like Leia, like
I was just about to say it's when she forced.
I watched it with my family and I almost got out of the theater. I was like, space isn't cold. You know, like you don't just become like frozen. You're just and you don't. And then she just like recovered, like nothing happened, and it was like she had like a bandage on her head and it was fine. It's like decompression, barrel trauma.
The barrel trauma decompression is what would get you right like within 10 seconds.
Yeah.
Because like U-2 pilots who have lost pressure in their suit, like they'll die in 10 seconds. Also, there's no.
How do you know that? And also tell me about your shirt for everyone.
Oh yeah. I did an elective at the Duke Hyperbaric Medicine Chambers, and most of hyperbarics is for like wound care, like diabetic foot ulcers, peripheral arterial disease, people with like neck necrotizing fasciitis, which is like a really bad infection like of your muscle tissue and fascial layers. They can get hyperbarics. But a lot of the research that's done in that chamber is for situations like where you're at like extreme altitudes, because you can go the opposite direction. So you can go hypobaric setting where the pressure is like 0.000 whatever atmospheres. But if you go to that low of a pressure, then the amount of the partial pressure of oxygen in the atmosphere is super low too. Like not enough to sustain life, which is why you need like supplemental oxygen. But it was really cool to be involved with that, to learn about like the research they're doing. They were doing a lot of like decompression research while I was there, so that was cool to see. And a lot of like the NASA astronauts will go either to those chambers or somewhere else around the country to do their like hypobaric testing, like seeing what their VO2 max and exercise capacity is when the partial pressure of oxygen is like super low, to see like what their baseline is.
Yeah,
a lot of cool stuff.
Yeah, it's a really cool elective. So 4 weeks at Duke, you get to play around the hyperbarics. Can you kind of like walk me through what you did as a student, like maybe an average day, or like if you were to tell someone that's going to do the elective, what's like if you were to teach the world one thing about hyperbarics, like what would you teach?
Well, I guess like the average each day it's a unique rotation because each day can be really different. Like it's such a research involved facility, because it's like a multi-place. So most hyperbaric chambers are monoplace. It's just like a singular tube in an emergency department that someone will sit in. But these are multi-place chambers. So it's like giant, like golf, like big balls that are the chambers themselves that can sit up to like 8 to 10 people, and also have like multiple animal subjects inside as well. So that like facilitates the research. So like On Monday, it could be more of like a clinic type day. But then like Tuesday, the whole day could be filled with research subjects like pigs and mice that you like actually send down to depth, and you can like test like different gases, different environments, and like test everything from like their exercise capacity, their VO2 max, some of their like blood work, like everything and anything. So it's like the interface between clinic, research, even ICU patients. Like I've never seen that type of interface in any other setting. Like at 1 p.m. we'll get an ICU patient, but then beforehand we're doing like a pig study. It's like every day is so variable and unique.
Yeah.
And then there's also like emergencies, so it's also almost like an EM department. So if someone comes in with DCS, like a diver, they'll actually fly them out to, like, and if they're near Duke, they'll fly them out to us, because I think we handle everything from Duke to Florida will come to our chambers to treat their DCS. If it's serious enough, like to where they need to go to a hyperbaric chamber to resolve. So.
And do you fly them?
Sometimes.
So
yeah.
We're talking about like the Benz or Caisson's disease, a disease where of divers that they go to depth, they're breathing compressed air, and when you reemerge from that, being at depth, you can have nitrogen gas build up in your blood if you don't have enough time to, or if you don't allow yourself to gradually surface. And so it's called DCS, but a bunch of other names I just threw around. And one of the ways that you can treat that is you essentially put them back at depth in the chamber, and obviously correct me if anything's wrong with this.
Yeah.
And then you gradually bring them up. But what I just alluded to is you might have to fly them, so bringing them, this disease can be precipitated by a diver who does a scuba dive and then within a day goes on an airplane, and they can kind of precipitate this reaction. So my joke was, how do you get them to Duke if they're in Florida? And the problem is that they got on the plane after scuba diving, they made the problem, so you just stay at a low altitude in the helicopter? Like what's the logistic of that, if you know?
Yeah, that is a good question. I don't know what the statistics are. I don't think it's that common for divers to get worsening DCS or even to have DCS symptoms unmasked when they go flying. But the recommendation is like not fly after you've been diving for at least, like 24 hours.
Yeah.
But in emergency, you will be flown out. But also like if it's a helicopter evac, for example, they're not going to go as high as like a commercial flight. But yeah, it is a risk because like not only you're going back to surface, but then you're even going higher slightly. But it's not like the commercial flights, like let's say they're at like, I think they pressurize the cabin to about 0.9 atmosphere or something. So it's like you're not that far off from surface.
Yeah.
Like it's not, the difference between, whatever depth you were diving at to surface is way greater than surface to commercial flight. So it's, I think the statistics are it's not that common that you'll like make DCS symptoms worse if you're trying to, bring someone to a facility.
Yeah.
But a lot of people have been like ground transported, like, I don't know, they just get, so what happens is like you won't always have your DCS symptoms like right after, so they'll have already been driving back. Like it's really common for someone, they're in Florida, they start driving back up north to go home, and then like 8-10 hours later they start having like shoulder pain, and sometimes you even get some dermatologic manifestations. It's called cutis murmurata. It's like this reddening, it's the actual nitrogen bubbles, like it's not like crepitus, it's hard to describe, but it's like,
Have you seen it?
I've seen it, yeah.
It's super cool.
It is cool, yeah. I've seen it in one diver, and then in the pig research that we did, it was like all over their body. It's called cutis murmurata. It's like a dermatologic finding. But a lot of times it will only present itself 6 to 10 hours after a dive, not like acute onset. You can have acute DCS, like if you just like horribly rise back up.
Yeah,
and
you're
then,
just
like,
a bad scuba diver.
Yeah. But you'd be surprised though, like even so one of the cool things we also did in the hyperbaric chamber, which I felt so incompetent doing, was like we did professional diving evaluations, and these aren't like hobbyists. Like I'm talking to someone whose career I might affect based off of my presentation to the attending. You know, if I say like, okay, this guy can't dive anymore, but this is this guy's life. Like we're trying to do everything possible to not stop him from diving, because like there'll be divers coming in who have like comorbid conditions, and we need to like evaluate the risks and benefits of like, can they continue their work versus like, are they going to die underwater?
So this is like the medical certificate for like an airman, but for a diver.
Exactly, it's the same. It's like I feel like pilots are taken pretty seriously during their yearly evals, like because flight surgeons understand it's their career, but they're still trying to let them know all the risks, like if they have any conditions that could affect.
Yeah. So last year's AsMA, the very beginning, had about an hour-long talk, like a keynote, essentially.
Mm-hmm.
And that talk pretty much summarized and projected forward the relationship between flight surgeons and their patients, and just talked about how pilots may look at FAA and FAA might look at pilots in a kind of antagonistic point of view, where that aviation medical examiner can take away your ticket to be a commercial pilot that you've worked on for your entire life.
Mm-hmm.
But they wanted to say that their take-home message was, we really want to be viewed as an agency that helps people fly with medical conditions, doesn't take away. And does that relate at all to things that you learned?
Oh, 100%. We will put people like on blood thinners and still say it's okay for them to dive, which is serious, because like it's like a 65-year-old guy, and if he hits his head in the boat, like he's dead. Like he'll bleed out.
Yeah.
But he needs to be on his blood thinner because like he's diving with like AFib. Like and we'll still let people dive like with AFib or with like heart failure.
Yeah, it's like you want to be the tool to help people with medical comorbidities to do the thing that they love to do.
Yeah.
If it's safe, within some degree of like caution.
Yeah. And I think I wouldn't say we push it to the extreme of letting people go. Like we'll definitely call it like quits when it's time, but it's like the line is like pretty up there for like what we're okay with letting go, like, or what we're okay with as optimally as we can treating, and still saying it's safe for them to dive. Yeah, which sounds like it's what the FAA and pilots kind of their relationship is too.
Are there like guidelines that were referenced, or like what's the person discretion?
So for hyperbarics, there's actually really strict guidelines for like treatment and stuff. There's like, and it's for billing too. Like there's only 14 things right now that we can bill for and get compensated appropriately that are covered under like the UHMS. It's like this big book. Like they actually had me read a lot of it during my rotation. So like for some reason I know a lot of the random things in it now.
Yeah. But
for the diving consults, it is like almost always up to the physician discretion. Like I didn't realize how little guidance there is, and like it could change week by week too, based off of the attending that we had too. So it wasn't I feel like with pilots it's a little more strict probably, but with divers like let's say someone has an arrhythmia, there's not like a strict set of guidelines saying like which arrhythmia will we never allow to go dive, like stuff like that, or even protocols of how to treat. I mean, there's like medical guidelines for how to treat arrhythmias, but not as it relates to diving though. It's just whatever we feel comfortable with. But the histories we take are some of the most detailed histories I've ever taken, because we need to ask like, have you ever fallen on the boat? Like, do you like feel like you hit your head against the equipment? How strong are you? Like, what's your exercise tolerance? So it's like, for example, if we put someone on a beta blocker, we don't want them to die for too long, because if they have to swim against a current, for example, and they're on a beta blocker, their heart might not get beat fast enough to like sustain that type of exercise tolerance. So it's like so many minute details like that that we take into consideration when putting like professional divers on meds and stuff. Yeah, it's not really guidelines, more just like the art of medicine, I guess.
Yeah, there is a lot of art of medicine that I've appreciated over the past year since we've recorded the last episode. It's a lot more of like personal discretion, personal kind of thinking, a lot more than I anticipated.
Mm-hmm.
So are you a diver as well? Do you dive?
Yeah, I have just an open water certification.
Just an open water.
Well,
I just have an open water as well, and Brian just has an open water.
I guess after meeting all these people who like they do crazy dives and like they dive on like nitrox, which is like a mixture of nitrogen and oxygen and stuff. Like I was just like a noob diver.
Vanilla.
But I think you have to dive at least once or twice a year to maintain your open water. But all the advanced certifications are like it's a lot of time and effort. But yeah, a lot of people in hyperbarics are divers, like which makes sense.
Yeah.
I think it's one of the cool things about this conference. I was just leafing through this, looking at some of the abstracts or things that are going to have a poster or be talked about in some way or form. And we were just talking about AFib, and I'm pretty sure I saw in here a few moments really before we started this recording that there was actually going to be a poster session on like how updates to the guidelines on AFib treatment have changed and how that relates to how they deal with this problem among like pilots or whomever.
Mm-hmm.
I forget the population, but definitely some really cool stuff coming up over the next few days on these things that it sounds like you see or talk about pretty often at a rotation like your barracks.
Yeah, for sure.
That's cool.
So what are you excited about tomorrow? We're the day before the conference, so we're kind of looking at the schedule, going, "Ooh, what do you want to see? What do you want to do? So what do you want to see and do?"
I know so. I guess for me, I think that I'm probably going to be someone who is a little unique, but maybe not in like a particularly special way. I don't know. It's kind of a weird way of framing it, but to reiterate that, I'm kind of a person who's coming in on the months leading up into my residency. This is kind of my vacation. I'm here with a really great friend of mine who I've known my whole life. so it was really an opportunity for me to be a big nerd about something I have a lot of passion for, hang out with people I love to travel with, and meet new faces and meet other people who also like to nerd out about things that I like to nerd out about. So that's kind of like my perspective coming in. Space medicine is something that I would love to make a part of my career, but and I don't know if you guys would relate to this. It's something we probably talked about in previous episodes of the podcast, but it's really one of those fields where it's like hard to like come up with a roadmap for how you would make this like your future. And I found that going through medical school and now finally, figuring out where I'm going to be for residency, I'm kind of learning about myself that I'm more of a like one step at a time kind of person. Mm-hmm. So at this point in my life, I think I'm more focused on, how am I going to do my internal medicine residency and come out as someone who would be a great hospitalist before I make the next, steps or make the decisions about my future, like whether I want to do a fellowship or whether I want to do something more in line with a possible future in aerospace. So to kind of come back full circle to what I said at the beginning, I'm coming here without like a plan, essentially, of like how this would be a part of my future, and I'm just here to learn. And for that reason, I don't think that there's like specific, poster sessions or things that I'm like super stoked about. It's really more just like the overall, just to being part of this scene. I think is really cool, and I'm hoping to meet people who maybe do have a little bit of a better vision and do have an idea of what a clear path to a future in space medicine looks like, and just talk to those people and hopefully one day maybe I can stand on their shoulders and when I'm figuring things out for myself.
Yeah, I mean, I think the way that you phrase that is like the exact right approach to like finding a sustainable career that's gravitated towards space applications, because I feel like I've more often encountered people that are like, okay, so I know 100% this thing's gonna happen in like 30 years, but I wanna be this career person in 30 years. What do I do to become that? Like, what are the steps in between? And I feel like that's, first of all, how do you know what even that is? And then that thing is also, that particular position 30 years down the road doesn't account for all the changes that are going to happen in that field in 30 years. So I think taking it step by step and saying, hey, I'm interested generally, and I'm going to be here, open to it, and see what happens, and focusing on being a good internal medicine resident, and figuring out if or how to weave this into your career is like,
Exactly.
that's the most like appropriate response. And second of all, if you need something to be really, if you want to look for something that's really exciting, come to my poster. Because obviously musculoskeletal health in space is the #1 problem, and should get all the grant funding and should be the most interesting. So yeah. Yeah. On that note, what I'm excited about, I think is on Wednesday, the herniated disc on ISS, diagnosis, treatment, and operational mission impacts. So this is just something I picked out because I think there's an active debate that I've brought up before between like what is happening to intervertebral discs in space, and this is like just shifting and just taking the conversation that direction. So astronauts get back pain. Would you expect that? I don't know if I would have expected that if I didn't know. And it's pretty common. I think it happens. I think roughly half of astronauts experience some sort of back pain.
When you say that, are you referring to while they're in space or after they're
in space?
Okay.
Yeah. So in space, imagine you're floating around. I shouldn't have any joint muscle pain. What am I doing? I'm not fighting against gravity. And but they end up developing lower back pain, and it's thought to be due to disc herniation. So you have a cartilaginous disc in between your bones of your spine that's surrounded by like kind of fibrous tissue that kind of keeps the jelly donut together. And part of the jelly donut kind of squish out if you don't have a good spinal column like muscle to keep it together. And so people are thinking that when you unload the spine, the disc actually becomes super hydrated. So gravitational forces and walking around like squishes all this like fluid out of the disc. And so it keeps them like a relative like homeostasis. But in space, you're not squishing it out, and so it's a really filled up jelly donut, and it squishes out. And on the other side of the camp, there's people that think that the muscle atrophy doesn't keep the jelly donut in the spinal column. And so, which one is it? It's really like a dichotomy. Is it both? Is it one or the other? And some of the most recent data I've seen, I guess it's now like a year or two old now, but has shown that it's more of a muscle problem than a superhydration problem. So I'm curious to see, one, is that still the case? And two, what's the most recent data on that? So I'm looking forward to that particular meeting. And hopefully I can talk to some musculoskeletal space people. Because there's not many of us.
Yeah.
A lot of people at this meeting are in general like what you would expect of like a kind of a flight surgeon crowd. So like emergency medicine, internal medicine, family medicine, and there's not that many people that are interested in like orthopedics or like sports medicine, that kind of stuff, or rehab.
Mm-hmm.
So yeah, hopefully gonna meet some cool people this time and talk about spines in space. So yeah, that's what I'm excited about.
I wonder, is muscle, going back to, I'm just interested about the disc
Yeah.
herniation. So it's like, generally is muscle atrophy and degradation happen at a faster rate or first before, any sort of bone or cartilage effects?
Yeah. So your question is like is the rate of bone or muscle loss, bone loss, or incidence of back pain,
Yeah.
does muscle drop off faster than bone?
Yeah.
And do those correspond to the onset of back pain?
Yeah.
So to answer the first question, muscle atrophies before bone. Bone's slower to respond.
Mm.
It's about 1% loss of bone mass per month in space.
Okay.
And I believe I'm pretty sure it's generally just greater in muscle. I don't know, I don't have any numbers to tell you. But the second question, I have no clue. So there's a question in the osteoporosis world, what percent bone loss do you need to start fracturing?
Mm-hmm.
So postmenopausal, a woman who's gone through menopause, they lose about 1% bone mass in certain areas like the femoral neck, the vertebrae, about 1% a year.
Mm-hmm.
So in space, 12 times faster, 1% per month. So, so you lose 1%. Do you all of a sudden fracture? What does losing 1% actually mean?
Mm-hmm.
So it gets into a deeper conversation, but there's a lot of fracture prediction software, or you look up on MedCalc the FRAX score.
Okay,
So
I didn't know about that score.
What's that?
I didn't know about that score.
So yeah, if you have
Okay.
if you have someone who's diabetic, or so pretty much in everyone who's over 60, especially women. So menopause occurs the largest range is probably 45 to 60.
Yeah.
It's it's a big range. So anyone who's older than that, and if they have any comorbid conditions or use tobacco or heavy drinkers, it can all affect your bone strength. And so you plug a bunch of things into a calculator, and it can determine your 10-year fracture risk.
Okay.
And so the relative strength of bone mass in that equation is pretty high, as you might imagine. But there's other independent predictors, if you're diabetic, you have a whole bunch of glucose running around in your bones, and it's makes you fragile.
Mm-hmm.
So yeah, it's not a one-to-one, and it's not, it's certain types of fracture mechanisms that lead to these types of problems. So, how much muscle and how much bone do you have to lose for someone to start getting intervertebral disc herniation? I actually don't know. So it would be I think your question is interesting, because if you're pointing towards a relative rate of muscle loss, then you would and if it was only a muscle problem, you would expect that the lower back pain would start after it reached a certain threshold.
Yeah.
And I would guess the hydration status of the disc would be much faster. That it would just be oh look, you're not squishing it out, so it just remains super hydrated after a day or two. So the actual paper I'm thinking of is by someone named Dr. Bailey out of UCSF. She's her Twitter handle is Spines in Space.
Nice.
She's very cool person active on Twitter, and very good human all around. And pretty much my one question for her, which wasn't really answered, was how fast. So they were only able to measure the stuff that was used in that study, before flight and after flight.
Mm-hmm.
So you can't. There's no MRI on the ISS.
Yeah.
And so I was wondering if they were not able to pick up any disk hydration changes that were significant. But I was wondering, like, within the time that the person landed and the time that they were able to get them to the MRI, whether or not they had switched out and changed the morphology of the disc at that point.
Well, that probably is exactly what happened, because that's why with these like mice experiments that are done in the ISS, like they have to be sacrificed like on the ISS like after 30 days.
Yeah.
Or even the ones, and then not only that, but then their tissue has to be preserved like on the ISS so that you maintain that exact like articular cartilage representation in microgravity. Because even re-entry back onto Earth would be enough to sort of change the data. Yeah. So even like definitely 4 hours. Like the time that it takes to land and then get to the MRI machine would be enough time to reacclimate to Earth gravity. Like your spine, I mean, not like in a general sense.
Yeah. It actually reminds me of something like, having been interested in space science for like a long time now, I obviously tell my parents about it. And my mom had one of these questions that I originally thought was like not that, didn't have like a lot of, it wasn't, she just doesn't know a lot about the field. And she was like, would you expect like a mouse that was like, sacrificed on the ISS to degrade or like to undergo like the disease process? Like how do the tissues react differently than one that, is sacrificed on Earth? And I was like, at first I kind of was like, it probably wouldn't be that different. Oh wait, I don't know anything about that. And I was like, that's such a good question. Like I have no idea.
That's a good question, because that's literally almost
it's
word
like,
for word the question I asked when I first started my research project. I'm like, why? They were just explaining to me, how the research was carried out, and I did ask, like, why are they sacrificed back here? Like, why are they like a day before travel sacrificing the ISS? And it is to maintain the exact state that they're in there, because it could potentially revert back to normal, like on landing.
Yeah, and I think it's like it would be tissue specific. So like it would make sense to do it for like looking at bone and muscle. But what my mom was getting at was like, what happens if like you're looking at gut microbiome and like for some reason like if the animal like had some weird reaction to being deceased in space, that would like change your outcome. Just like it was kind of like a funny thing she brought up. But yeah, that's I think there's not that many musculoskeletal people in the space world, and I don't know. I found it interesting. I've recently read a lot of science fiction books since I've finished third year, and almost all of the science fiction authors like talk about like if they ever mention like the biological component of whatever they're talking about, they almost always talk about muscle and bone, like as like the long-term kind of effects. So hopefully one day people will get more interested.
Yeah.
Kyle, is that figure that you mentioned, the 1% bone loss per month, is that, I'm just curious about this, is this like in spite of the most up-to-date like exercise regimens on humans, or is this like based on,
like
at some point like a decade ago or something, or like when did they come up with that?
So a lot of this work was done by Dr. Jean Sabanga, and she's like a musculoskeletal researcher at NASA. So she is essentially like the subject matter expert for all that cool stuff. And she compared essentially like baseline just using the treadmill on the ISS and using the ARED, which is like the deadlifting apparatus.
Yeah.
And so that 1% per month is generic. so it happens. So it's 1% per month at the femoral neck. So where your thigh bone meets your hip. There's like a little bony bridge that when people say, "Oh, you fractured your hip," you're actually fracturing this part of the bone. And so it's like very prone to osteoporotic fracture. And so there, and then your actual like your vertebrae, those can undergo compression fractures. And so those are the two areas that are most affected. And actually you can get additions to bone, like on your upper limbs. Like so your upper arm and like your head, you actually gain a little bit of bone. So that 1% is like very much like an unsophisticated thing that you have in your pocket. So the real answer is that despite exercise countermeasures, there still is significant bone loss. I don't have the exact number on my hand, out of my pocket, but I think it's similar to that 1% margin. So the short of it is exercise countermeasures help, but are not sufficient to prevent bone loss.
Sure.
So this is like a debate that I think I started out like my space medicine interest in was, okay, well, you have bone loss happening and exercise isn't able to stop it. Okay, so exercise can't stop it. Where do you go as a doctor? You give a drug. And what do we give for osteoporotic patients? Bisphosphonates, right? And so actually at the talk where I met Dr. Sabanga, there was a whole bunch of discussion about, okay, so if you want to prescribe someone a bisphosphonate, you may have remembered that you have to also have them educate your patient and say, you need to be sitting up and you need to drink a glass of water afterwards. And why is that? The number one one of the major complications of this type of drug is esophagitis.
Yeah.
So the pill going down, the tube between your mouth and your stomach causes irritation. And so you use these things to help the transit of the pill to go faster. So in space, if you were to have the pill, yeah, exactly. So you could have more esophagitis. And so flight surgeons have, they say, okay, well, we're not sure about this fracture thing that is theoretical and hasn't been borne out in the longitudinal data yet. I am not going to risk it. Maybe we can do it for a study. There was one study where they actually did give astronauts bisphosphonate drugs for study. But it's not done because it introduces risk. So it introduces that esophagitis as well as osteonecrosis of the jaw, ONJ. And so it's like, okay, well, you're going to hopefully prevent something theoretical, maybe non-tangible in the future, or you're going to potentially introduce a risk now. As a flight surgeon, who's going to be preventative medicine, who's interested in more of what's happening during the mission right now rather than some theoretical risks, they have opted not to. So there is a tension in terms of the basic scientists who are like, the reason we haven't been able to see astronauts in these longitudinal surveys about their skeletal health fracture more often versus not is we haven't looked at them for long enough. They're not old enough yet.
Okay. Yeah.
So it's like so astronauts are essentially guinea pigs for life. They undergo skeletal surveys routinely. They undergo health surveys for a long time, and the population data of astronauts versus normal people, non-astronauts, hasn't been able to show that they're X% or X multiplier of a fracture risk. But there's many reasons that go into fracture risk besides, all the things I just talked about.
Yeah, and generally astronauts are some of the healthiest
subset
of the population.
So yes, the flight surgeon's like, well, I have the healthiest, potential patient. I don't need to give them this drug. They'll be okay, and we can recover it. So that's kind of that's some of the tension in the musculoskeletal field. And there actually was a recent study by investigator who was looking at like traumatic, like bone loss. I forget from what. I think it was like it was some military application, but she was really wondering how much bone you could potentially gain from someone who was like osteopenic, like an adult who was like otherwise like healthy, but was wondering like what percent bone mass you could like just like add on to someone through exercise. And she found that the bone is much more dynamic than a lot of people like to think. So people like to think that they're these like lead pipes that like just hold people up, right?
Yeah.
Which they certainly do. They certainly do, but they're definitely, they're very, very responsive to mechanical loads and, really important in terms of like endocrine, like calcium function too. So, just some things that are interesting in my world. And excited to present some of my work. Just in short, for people who like The Expanse, I call it the Belter hypothesis, where
I still haven't watched that show.
You still have not?
I haven't seen it. But I feel like it's like the epitome of like aerospace medicine shows or just space shows in general.
Yeah. Science fiction. The feedback between my work is the feedback between science fiction and science, and a lot of the time, it goes both ways. Mm-hmm. So science can influence science fiction. So I was like, okay, well, all these science fiction authors I've read, they all talk about like these bird bones, like these bones that are like longer and more slender and compared to Earth people. And I was like, is that right? I don't know. So I looked into it, and I honestly, I don't know where they're getting this information from. Like what they base is it purely like their fever dream of like these space people?
Yeah.
I don't think they looked up like basic science, bone biology stuff.
No.
So I look, and it's very limited because the question was specific. It was, do people with developing skeletons, so people that have not undergone like their growth plate closing, when they are most sensitive to like mechanical forces, does like the bone lengthening biology change when you have like less or no mechanical loads? Do these growth plates close or not, or the same way or not? And so I found some data on like the open source, like the NASA like Ames Life Science Data Archive. It now has a different name, but essentially found that spaceflight animals compared to ground animals, the spaceflight animals had a 1 to 1.5% longer bones. Like they're straight up longer.
Yeah.
Just like, it's a very simple question. Are they longer? Are they more slender? And so I don't know, it's just a very simple thing, and it came out to, they weren't significantly longer, so the distribution between the groups wasn't tight enough to make the stats work out. But I feel like given a long enough time, a 1 to 1.5% difference magnified over, instead of a 4-week mission, like an 8-week or a 6-month mission, potentially your bones get longer if you go to space, which is like wild. And so a lot of the research is like, well, we talk about bone loss, like we're just talking about it a lot, because we think about adults going to space. Mm-hmm. But what happens when we take kids?
Well, I can tell you a lot of bad stuff happens. Like during my newborn nursery week, my presentation was on the viability of childbirth in space, because ultimately that's what's going to have to happen for any concept of continuing deep space exploration. That's why earlier when we were talking today, I was saying like cardiovascular health plus nutrition, and then the third thing is like reproduction. Mm-hmm. But it's like totally unfeasible to have a gestation right now in space. Totally unfeasible.
So what are some of the
like everything you can imagine will go wrong. Like there'll be like rickets babies. They'll have like polyhydramnios. Mm-hmm. they will just not be able to even give birth in a microgravity environment. Like we definitely need to replicate gravity before any concept of gestation. And but the interesting thing was the mice or the rats they sent up to the ISS that had the gestation in ISS but then delivered back on Earth, their babies were fine. But the ones that delivered on the ISS, like their babies did not survive more than like a few hours.
And did they have any bones that I can look at?
I don't know. I didn't look into if they went into that much detail, like in terms of their bone health. But I think a lot of the flight surgeons like were predicting like if we were somehow to be able to reproduce over the course of 4 or 5 generations in a microgravity environment, like those humans would look a lot different, like both in skin color, and because of the exposure to like galactic radiation, it would change their skin color. Like it would probably be like a dusty gray type of color, and then they would have like their heads would probably be slightly bigger, like frontal blossoming, with like deficiency of vitamin D, like what rickets babies look like. But they'd probably be like normal for them, and also a bit of hydrocephalus probably because of the fluid shift.
Yeah.
So sometimes I think like that's where the concept of aliens came from, like because that's what you think of.
Yeah.
But they would be like humanoid, but it would just look different than us, like in a lot of ways. But yeah, like I feel like a lot of what you talked about, like with the growth plates and everything, it's like if you're a developing fetus and then you're born in that environment, like it's a little bit unsustainable right now.
Yeah.
Just because we've evolved to be born and undergo gestation in gravity.
Yeah.
So I'm not sure. I don't know what the answer is.
Yeah. So what was the study that like the specific? Do you have any specific names of that study?
Yeah, I don't. It's in my presentation. I forget. I'm so bad with like name. I feel like people are really good with names and authors, but it is public stuff on NASA.
Okay.
Yeah, so you can find it. I think it's on their. What's the site called? Where they
Data archive.
Yeah, their data archive.
Yeah.
Because that's mainly what I used for my newborn nursery presentation. But they thought it was an interesting presentation because for like my attending all the years she's been doing it, it's someone presents about like how useful is the moral reflex or like just the newborn nursery things you learn, and then I just come out of the space nerd out of nowhere like can we deliver in space, which is important, like knowing a lot of stuff about there's so many facets we think about in terms of the types of physicians you'll need for long-term duration missions, but like a pediatrician would be vitally important, like someone who understands, and also like in an aerospace context, someone who understands like gestation and complications and like how to deliver a baby.
Were you alluding to a presentation that you're going to be doing at this conference?
No, it was a presentation I gave during the week. Like some med students have to give presentations.
Gotcha. Right.
Yeah.
You did something similar.
I did. Yeah, I had something like that for my surgery rotation. I talked about like a debate that's been kind of going on for decades, really, about whether or not maybe astronauts or people who are going to go to like extreme environments where there isn't really good healthcare available, whether they should have like their appendix taken out or like their gallbladder taken out before they even go.
Oh,
And
that's
so,
super interesting.
Yeah, prophylactic appendectomy or cholecystectomy.
Oh, wow.
And what is it? What's
There's
the right answer?
Yeah, I mean, I think
Don't some astronauts do that? Like, I feel like I've read something about where some astronauts have had like their appendix taken out before missions.
I can't really, I couldn't name like a specific astronaut that I found, or at least I can't recall one. I do know that there are like certain communities, even on Earth, that like will require you to have your appendix removed or something, like to live in an Antarctic town or something like that.
Okay.
So it was like the medical officer for the Australian, like from Australia. Like if to serve as a medical officer in Antarctica, you have to have an appendectomy. Or it's either it's somewhere in the oceanic region.
Yeah.
But yeah, that was, I remember that from your presentation. Where it's
Yeah, it's neat stuff for sure. Cool.
But again, from like a preventative standpoint, like almost every flight student I've ever talked to is like, we do not recommend that.
Yeah.
We don't, like, would you introduce, it's just a bag of worms. Why are you introducing a risk?
Yeah, the risk of the procedure and
Yeah,
everything.
it's like, and who says? And like, you know, one of the big trends in general surgery over the past like year or two is like, hey, appendectomies, they can be kind of bad and we can just give you antibiotics and it can be okay. So that's been like a big shift. And you know, before it was like, oh, your appendix hurts, so let's get it out of you. And now it's a little bit more nuanced.
Yeah.
I was gonna ask you, Kyle, like what was your introduction to aerospace medicine? Like, how did you get involved in all of this?
Yeah.
Were you always like interested from a young age?
Yeah, so I had no idea that space medicine existed.
Okay.
Until like it was like the summer between undergrad and or like I took a gap year between undergrad and like trying to figure my life out.
Mm-hmm.
So the year was like 2013, 2014.
Mm-hmm.
I was working in a lab at the time and I was trying to figure out what to do with my life.
Yeah.
Pretty much. You know, apply to med school, apply to grad school, and so I decided to do like a master's program and to try to figure out like, am I good at research? Should I do it? You know, essentially like also help out with like medical school stuff.
Mm-hmm.
And during that process of finding like the right program, I had studied abroad in England, so I was like, oh, I should like go like try and like I should do something fun for a year.
Yeah.
And so I found, I went to one of the universities and was looking up like different biology, like masters to do. And like, there was like one page, I was looking at the directory, I remember this moment. And I had like, it's like page 1 of 2, and it had like all of these, and I'm like, okay, well, let's look at page 2. And it's like, literally there's one program at the very end, and it was space physiology and health, offered by King's College London.
Mm-hmm.
And it was like it's still or I don't think it's still running, but it's a very unique, or was a very unique program.
Yeah, Ben said they stopped.
Yeah.
I talked to him this morning.
Yeah.
Because he was there.
Yeah.
But yeah, he said I think like last year they stopped it.
Yeah, I think it's been a couple years.
Is it a COVID casualty or just?
I'm
not
sure.
Yeah, this is Ben Johnson is like he's a fourth. Did he graduate in MASH?
He said his graduation is next Wednesday.
Yeah, so he's.
I did ask him where he matched.
Yeah, so he is a fourth year, was a fourth year at Hopkins. And he's the president of AsMA.
Yeah.
And so really nice guy. Was able to meet him last year. He's interested in emergency medicine. At least last time I talked to him. And yeah, he wants to do like the flight surgery route, and he did this program and kind of connected over that. So I found this program and was like, this is the coolest thing ever. But I ended up not going.
Oh, okay.
I ended up like not thinking that it was the right thing for me. And so to answer your question, that is when I found out about the field.
Okay.
There's many reasons why I didn't do it. The first being I didn't know I thought that it was like somehow committing me to something where I didn't know, like, oh, I have to be a flight surgeon now. I have to be a space doctor now. Like, it's like too soon. Like, I just found out about this thing. And obviously, like, educational decisions like that, they don't carry as much like finality as many people think. So I think that was a little naive in me. But I didn't know how it would be seen to medical schools, or I didn't know how to incorporate it into my life. And so actually for a period of time, I had a lot of like regret about it. I was like, oh man, I totally missed out on this opportunity. And I don't have that regret anymore. it either has like sublimated into my interest in the field. So I've tried to like use it for good, like that level of like, oh, I should have like done this program.
Yeah.
So I think a lot of my energy kind of comes from that, trying to compensate for that and be like, okay, well, now I've got to make up for lost time now. But yeah, I feel like the logic behind getting involved in this field, I have a preference, and that preference is I prefer to come from the outside in. And what I mean by that is like become a specialist in something that you are gonna do, like quote unquote like normal medicine, something that you're passionate about that you can do on a day-to-day basis, and then eventually apply that to space. Because if you start out just liking space stuff only, and you'd only ever be happy taking care of space things, it's like that job doesn't really exist. Like you can't do it that way. It isn't cut that way. I don't know if that makes sense how I described that, but you have to start out by being a good internal medicine doctor, to start out being a good anesthesiologist, to then find out how to apply those skills to space. Because there's not enough people going to space for you just to specialize in space.
Yeah.
So that was kind of my thinking, and so I was like, okay, well, I need to like go do this medical school stuff and graduate school stuff first, and figure out what I want to do in space before I can be useful in doing this master's program. So that's why I decided not to do it. But yeah, that's what I found out, and ever since I've given talks about like the development of like denosumab and like how like spatial emissions were used to like validate it for osteoporosis research. I got involved as like an early like medical student in a NASA project, and that kind of like fostered the whole reason that I wanted to do a PhD. So I ended up doing that. But my PhD wasn't in space medicine bone stuff because there's not enough work to, it's the same theme.
Yeah.
So I got involved in a project that wanted to look at the osteocyte. So bone is primarily comprised of these cells called osteocytes that have these like neuron-like projections that feel mechanical stress. So they're out there like sitting like they have like these little like trees, and they can feel like fluid shearing across their membrane. And if they feel more shearing, they tell the other cells of the bone, the osteoclasts and the osteoblasts, the ones that take down bone, the ones that build bone, what to do. And so people they've looked at osteoclasts a lot. Everyone knows about osteoclasts, but osteoblasts are much cooler. And so there was some thinking by some investigators that the osteocyte might be acting weirdly in space. And so I got involved in this project early on, and then I just kept on volunteering in the lab, and then if you do that for long enough, you can get a PhD. many years later. So yeah, that's kind of wrapped up that. I guess actually that has changed since last time. No, actually, I graduated by last AsMA.
Wait, so did you do M1 and M2 and then PhD?
Yeah.
Okay.
Yeah, so at my school, they don't have a program, like an MSTP program, so like the NIH funded, types of programs where you like apply into it at the beginning.
Yeah.
I kind of was like, I did it a little atypically and said, hey, I have this interest, I want to do research. I felt like I was bad at science, like doing research is like really hard, at least for me. It's probably pretty easy for some people, but I think doing good science is hard. And I was like, you know what? I want to get better at it. And so that's why I decided to do it. It's like that's the primary reason. Because people, who go to medical school and graduate to residency, guess what? You can do science too. you don't need a PhD to do science.
Yeah.
Like you need, it's important that you can develop those science skills, as you go. And that's like, you don't need to subject yourself to all of that, all the BS of graduate school. But I felt like I needed it because I thought science was hard, and it is hard, and I'm not good at it. I'm a little bit better than when I started. So, yeah, that's kind of my little diatribe about MD PhD. It's just like, if you really want to do it, and you have to convince the graduate school and the medical school to let you do it, then you should do it. But otherwise, just go through med school or just do grad school. That's all I need. Yeah.
Yeah, but look at you now, man. I feel like you say that, but I think the project you already mentioned that you're going to be presenting at here, like this is like an idea that you came up with on your own. You like reached out to people on your own, did all this stuff independent of a lab. I feel like if there's a way to be good at science, doing it yourself is definitely like the hardest. It's like the hardest, most difficult thing that you could probably do. Yeah. So kudos to you. And maybe you're better at this whole science thing than you're leading on.
I mean, I certainly spending enough time on it, you would hope that you're you're good enough. But the types of schools that we've been through don't really breed, at least for me, have never said, oh yeah, you should feel good enough. Like medical school and graduate school, at least for me, has always made me feel like I'm not good enough. So
that's pretty accurate.
Yeah, it's like oh yeah, I'm just like a little tadpole in this big part. But yeah, so I don't know. The problem is like doing this project quote unquote by myself is I don't know if it's like. That's why I'm here. Like I'm here to talk to people who may know something, and I need other people to comment on it because I don't know if what I have observed in my data is real, or if it's plausible, or what are the possible mechanisms for what could be happening, and that's why I go to conferences. That is for me that's the most genuine reason to come to conferences. Because I've been to a lot of other conferences, and a lot of the time it's presenting data because your PI really wants you to show off your paper but you're not actively trying to find someone to help you to figure this thing out that you're actively usually presenting on a paper that's about to be published or part of a paper that you've been a part of. So I don't know, I'm really excited to talk to people here because they might, while they're probably not, bone biologists, they probably have some other insight that I could consider going forward, and that's the reason that you come to conference. At least for me. So I'm super excited to be here, and super excited to meet you and to hang out with you, and it's this is I call this either the Super Bowl of space medicine or New Year's Day or Christmas Day or whatever, because it's so exciting to be around these people and to look at the conference program and be like, holy crap, I want to go to this, I want to go to that, I want to meet all these people.
The Zoom calls we have once a month, it's everyone gets really excited about it, but now it's just all in 5 days, all the topics that we want to go to. So I'm definitely excited about it. And definitely what you're talking about, the poster presentation, I do feel in other aspects when I've been to poster presentations, no one's going to be critical enough or give you very valuable information. It's just even for an undergrad one, it's just more of can you present your findings well, and like that's what you're evaluated on. Like, but like here, like people's comments about your research can carry so much value and weight, because one, this field is like pretty niche. It's not like, you know, a huge field that people all everywhere are involved in. And then like their expertise is that much more valuable, like if they have something to input to your research, or if they do similar research and can kind of comment on what they've seen.
Yeah.
Like,
yeah, it has so much, you know, so many good people to meet, so much good information to learn, and so much good food and music to enjoy.
Oh yeah.
Here in New Orleans. Yeah. Yeah, really excited.
Dude, I think one thing that's really cool is just the this conference also being like an intersection of the different like entities that are involved in this space. Like you've got military people, you've got commercial like SpaceX people, and you've got NASA people, and it's all happening in one building. I think that's really neat, especially as someone who is really like looking into all the different possibilities and ways that people have like found to make their life focused on this subject.
Yeah.
Like it's just great to see all of these different people who have, in a sense, like made it in some way or fashion, and are here, you know, like you discussing like their work.
Yeah.
So that's great.
Yeah. Any like kind of final thoughts you guys have? Any
I
like
guess I've been kind of leaning on the comment you made way earlier in this about you're taking things one step at a time, focusing on being the best internal medicine resident and like hospitalist you can be, and then you're not exactly sure. I guess maybe none of us aren't exactly sure what career path we're going to take, but to some extent that is what I like most about aerospace medicine. And I don't know if it's like a naive comment to say, but almost like a lot of the medical specialties, like we know exactly what's going to happen. Like if I want to go into pain medicine, or if I want to become like a hand specialist, like there's no variability. Like you know exactly the steps you're going to take, residency, fellowship. Like maybe you don't know geographically where you're going to go, but it's like the path is very clear, and it's like kind of fun for me that I have no idea what's going to happen.
Yeah.
Like that is really part of like, I mean, I don't want to use the term like boring for other specialties, because I don't think other specialties are boring. Like I think, you know, the job of like an interventional cardiologist is very intense and cool, but like for us that are considering aerospace medicine, especially the fields that haven't been quite as involved in it, like with orthopedic surgery or me as an anesthesiologist, it's like there is no path, and so like not having that clear final destination is like part of the fun for me.
Yeah.
It like makes the journey interesting.
Yeah. Yeah, like instead of following a path, beating your own path.
Yeah.
And that's just like, it's a, you know, the field is about frontiers.
Yes.
And it's like, but it's also that your journey in it is your own frontier. That's just, yeah.
Yeah. And I think like ultimately like to have balance, like I know you before we hit record, like you were asking like what my final career goals are.
Right.
And it is always like I'm very risk averse in the sense like I need to know I have an income and a stable job as an anesthesiologist. And like part of the reason I think like EM and anesthesiology are good fits is because like of the nature of the work. Like it's not like I'm not carrying like a patient panel that I can just abandon, like, you know, if I was an FM physician to go do like a mission or something.
Yeah.
But with like EM or anesthesia, for example, I feel like you can practice that on certain days and then, you know, come in and be like a mission specialist or aid in research or like be a flight surgeon at specific times. But I would definitely want to maintain the skills of the specialty that I started into. Because like I do feel like I don't know if I ever even wanted to be like a general flight surgeon. I do want to be very good at the specialty that I choose and apply that into if I do have a aerospace medicine adjacent career. So Yeah, we'll see how that works.
Yeah. Yeah, as I already said, like I feel like that's, unless you're really gung-ho about doing flight surgery, like through and through, you know, the number of jobs of being a flight surgeon, you know, let's say it's like 10.
Mm-hmm.
The number of jobs adjacent to flight surgery is probably close to 100. Like it's just the number of people that have to be involved to support a mission that's maybe not taken care of, like at mission control, being the flight surgeon on console. Like there's just many other people that need to be a part of it, and they, like every flight surgeon I've talked to, they desperately want good people to help comment on flight surgery problems. So like if you're a radiologist, like most people will be like, oh well, you can't do space medicine. Like what possibly could you do? There's no MRI, there's no CT on the space station. But what they want is someone to help interpret like imaging and like to do all these particular things to radiology that flight surgeons know about, like they're very well versed in all these capabilities, but they need, they consult services, just like internal medicine does at the hospital.
Yeah.
And
they do that pretty often too.
Yeah. And the one thing to put in there, talking to these flight surgeons, those relationships, so say you're interested in like a specialty like dermatology, the way that you become the dermatologist for NASA is organic. There's no one way to do it, and you have to be that person that's either that lives in Houston and like knows all these people, or probably because of telemedicine, like you could probably just either do research in the field or just get your foot in the door some other way, and then you can just gradually become that person. You can't wait for someone to be like, okay, here's the path that you need to take. Like go out and seek it, like go out and like try it. And there's not that many of you probably that are interested in dermatology and space. Yeah. But you're needed, and you got to go out and get it. And there's no other way around it. Yeah. Not a little soapbox. All right. Well, I guess last thing we'll say to kind of wrap things up. Like, what do you think? I guess I'll pose two questions each for you. First one would be like, what do you think you'll learn at this conference? Or like, where do you see aerospace medicine over the next 10 years? Like, there's two very different questions, but like, do any of them seem interesting for you to answer?
I think those are both like great questions to contemplate. They're definitely more. The first one is something that I think is a little more readily answerable.
Yeah.
For me, something that I've been kind of mulling over in my head as a potential way to get closer to the field of space medicine is going more into a military route. So I've kind of always been someone who really like enjoyed the civilian angle and a lot of the, all the liberty that comes with, not really being dependent on another agency telling you really where you have to be and what you're going to be able to do. But more and more, just lately I've been thinking a lot about the offerings that the Air Force in particular has in ways that this could make my life more interesting. I think that's like almost a generational thing. I think a lot of people our age or younger are like really focused on how do I do a job but have it be more than just like a 9 to 5. Mm-hmm. And space medicine is definitely like my answer to that. And I think potentially the Air Force route in that direction could be something as well. So I'm hoping to meet people who specifically have contemplated throwing in their lot with the Air Force at the beginning of residency, as opposed to like starting, way back in undergrad or before med school, and talk to them and see what they have to say, the stipulations that come with that kind of responsibility. And then the second question about where I see things going in the next 10 years, I think it's really going to just depend on how much much the commercial sector like leans into things. I think definitely we've been having a lot of momentum with SpaceX, and it seems like there's a lot of agencies out there like Blue Origin that are really just starting to dip their toes in the water. And I don't know if it's clear yet how fast these companies are going to like swoop in and really like steal the show away from governmental programs. So I think it could maybe be a lot bigger in 10 years than it is today. And I think that these companies could really be, hiring the specialists. Like right now, we're all sitting here kind of talking about how maybe the most likely outcome if you want to be involved in space medicine is to do, like you said, like space medicine adjacent. Like you're not necessarily a flight surgeon, but you're like someone who is able to offer a lot of insight from their specialty and how that specialty relates to what a flight surgeon might see. And I think with commercial spaceflight, we might actually, have more positions, more interest in long-term stuff, more interest in sending people who aren't the healthiest candidate, the William Shatners and the elderly, young people, children, just everyone in between, and the degree to which they are able to do that affordably is going to determine a lot. I think. Hopefully, it's a lot.
Yep,
we'll see.
I mean, you pretty much answered what my response would have been for the second question. I do hope also that in 10 years it's more like collaborative internationally as well, which like to some extent it is right now, but I feel like a lot of the aerospace programs like in Australia and the UK are like a bit lacking. Like I know in the European Space Agency, like I don't know how often they do astronaut candidacy, but it's like I know it's a big deal when they do it because like everyone around the country applies, and so it's like pretty minimal there. So I'm hoping like more international collaboration. Like I just think stuff like that is really important too. And then hopefully more like job opportunities for us, as all these private industries keep growing and expanding. And I do think they have a little bit of an issue because and we've heard it in previous Zoom calls about how they're hiring like physicians that don't have the best background in aerospace, like SpaceX and stuff, and it's like that's part of the reason why they're building out all these fellowships is to like train mission specialists who are like very well versed in aerospace medicine to like deal with these issues.
So we were just kind of talking about like what you hope to learn and where's aerospace medicine going in 10 years. Ryan said you're hoping to learn a lot about like the Air Force and how to essentially like incorporate that into your life in different ways. And most in the 10 years, like the biggest factor will be the big question mark in the room, which is commercial space. Like, how much is it going to explode? Is it going to be this big of an explosion? Like, we're pretty sure there's going to be an explosion. I mean, literally today is the Axiom 2 launch. Like another like SpaceX's like 5th or 6th or 7th like human rated spaceflight launch, which like has been a resounding success from NASA's point of view, most likely. And it's like, is the explosion going to continue? It's not guaranteed. And so, what's going to happen over the next 10 years is going to be, what is that going to happen? What's going to happen with that? I should say. And then, largely you were like, I agree. Like, civilian space flight's like going to be the hot money. And what you were most interested in. Actually, what was that thing again that you were most interested in?
Oh yeah, or what I hope to learn.
Yeah, what we hope to learn. Yeah.
But one thing, quickly going back to what we're going to see in 10 years, I think we're actually going to have to take a lot of the experience that UHMS has had because, well,
you're biased, obviously.
I'm definitely biased, but
so the undersea
UHMS has been dealing with the most intense comorbid conditions with professional divers. But how many astronauts have gone up who are like in like stage 3, like kidney disease, like I mean, like even like the the older billionaires that have gone up, like I don't know their health, but like I feel like they weren't like actively dying or had like crazy comorbid complications, but like imagine we all get that patient that comes into the hospital with like 20 different medical problems, like, and what if that person wants to go on a trip? Like, have we ever sent someone like that to space? So we might have to take a lot of advice from divers, like who do have those conditions, just and apply it from an aerospace perspective. So I think we're going to be actively learning about those conditions and how, whether they're exacerbated or not, and maybe like lower Earth orbit and potentially the ISS. Because right now it's like, I feel like a lot of the research is like we take someone healthy and see how slightly unhealthier they get.
Yeah.
Like, but can
as opposed like a healthy person to unhealthy environment.
Exactly. Yeah.
Not an unhealthy person and an unhealthy.
Yeah. But what about someone with CHF, like that's going to go up to the ISS? Like, how is that fluid shift even going to look like on them?
Yeah.
Like, where is it going to mostly pool? Like, what is the exam going to look like? We've never, at least I don't think so, have encountered stuff like that yet.
I wonder. Yeah, I have so many questions just about that sentence. Because it's like, all right, so if all your fluid is like leaking into like the a non-vascular space, like do you get the cranial shift as much?
Yeah.
Like, are you gonna have sands as much? I don't know.
Yeah, it's so that I think, like, I don't even know how the first people with comorbid conditions are going to be approached, like, because it's pretty strict right now. Like, you're not, well, from an astronaut perspective, you're not going to go, but as like lower Earth orbit becomes more commercialized, like maybe even to the point where it's a form of like transportation, like then like we'll see more people like that.
Yeah.
And maybe we can go off of the studies that are done just on normal like commercial flights, because people are told not to fly after like certain procedures and surgeries, so like we'll definitely use that data first, but I don't know how that's going to apply like in a microgravity environment. And then the first question, which is like what I guess I'm excited to like learn about, I think one, definitely like every time I talk to people, I find out about more complications related to spaceflight. Like even this year, like nutrition was never in the front of my mind, but it's become something that I think is critically important after all the talks that I've been to. So I'm interested in just finding out what other people value or think is important to investigate.
Yeah.
Because everyone has like a different perspective, and it's like a pretty valuable perspective, because the people that are telling me about this, like they've mostly dedicated a lot of research and time into like what they're investigating. So it's very interesting to hear what they say. It's not just like some like opinion off the street or and then also excited to like talk to like some flight surgeons and see what their life is like, because like for me like work-life balance is a big thing, and it's kind of just like a foreign concept as a medical student. Like that's why like we like ask attendings what their lifestyle is like all the time is like, and for me like I have no idea. I get different answers every time I ask a flight surgeon, like what, like are they with their family most of the week, or like do they travel overseas pretty often? So like I like asking those types of questions to current flight surgeons and like seeing just what their daily life is like.
Yeah.
So that's what I'm excited to learn about.
Yeah.
Yeah.
Yeah, we'll have to check back in. The hopeful plan is we'll do at least one like recap of the event, so we'll have to compare these answers
Yeah.
to after the event, because things will change and hopefully we'll learn things that we didn't expect. So. All right, well, we've been at it for probably about 90 minutes actually.
Nice.
So we used to make these podcasts about an hour and a half to reflect the orbit of the International Space Station. We call them orbits. So thanks for joining us for this most recent orbit, and we'll catch you next time around.